topic for today is Thrombospondin type 1 domain containing 7A in idiopathic membranous nephropathy. Definition: Idiopathic membranous nephropathy is an autoimmune disease and uncommon cause of the nephrotic syndrome in adults. In addition, patients who have membranous nephropathy with nephrotic syndrome have significant morbidity and mortality, in particular related to thromboembolic and cardiovascular complications. Now a video.
My name is Fernando Forvenza. I'm a nephrologist at the Mayo Clinic in Rochester, Minnesota. My topic is membranous nephropathy, new insights regarding treatment. But before we proceed to discuss immunosuppressive treatment in patient membranous nephropathy, I would like to point out to you that the best prognostic factor for renal survival in these patients is the achievement of complete remission of proteinuria. Even patients with membranous nephropathy that achieve a partial remission have a very good long-term renal survival. But persistence of nephrotic syndrome is associated with a high risk of reaching end-stage renal disease. The risk can be as high as 80% in long-term follow-up, as reported by the Toronto group a few years ago. The goal of therapy is to reduce proteinuria, because reduction of proteinuria in patients with membranous nephropathy equals to long-term prevention of those patients to progress to end-stage renal disease. Now, we do have a number of studies that has shown that the best therapy, in fact, to achieve remission of proteinuria in patients with membranous nephropathy is the combined use of cytotoxic medications with high-dose steroids. And this was illustrated by this study by Dr. Ponticelli, published some years ago in Kidney International, that showed that patients with membranous nephropathy that underwent treatment with prednisone alternating with cyclophosphamide or chlorambucil had a much higher long-term renal survival than patients that were treated without immunosuppressive therapy. Now, we also have data from the use of calcineurin inhibitors, both cyclosporin and tacrolimus. And I just like to illustrate with this study done by Manuel Praga and collaborators, where they use tacrolimus monotherapy to treat patients with idiopathic membranous nephropathy. And you can see that use of this medication up to 18 months result in a 76% incidence of achieving complete or partial remission. The problem with tacrolimus, which is also the problem with cyclosporin, is that once you stop this medication, there is a high risk of relapse of the disease, as illustrated by the Praga study, where when we look further down 30 months, the majority of those patients have had a relapse of their nephrotic syndrome. There is additional problems with the traditional therapies, mainly concern the potential side effects associated with these therapies. And this can be illustrated by the risk of infertility and long-term risk of malignancy with the use of the cytotoxic agents, and the risk of nephrotoxicity with the patients using a calcineurin inhibitor, since many of those patients will become calcineurin dependent and therefore requiring long-term use of those medications with the potential side effect that would include a nephrotoxicity in this population. Another problem with the cytotoxic medications is that although they do represent the best available data for treatment of membranous nephropathy, is that they are also not immune of the complication of relapse. And as illustrated by this study by Dr. Ponticelli, that's showing that patients treated with either chlorambucil or cyclophosphamide have a 30% risk of relapse once the treatment is stopped. It has been argued that there is an unmet need for effective therapy with a favorable safety profile where the risk-benefit favors early initiation of therapy in patients with membranous nephropathy. Now, to this aim, the group in the Netherlands treated patients with a combination of prednisone and mycophenolic mofetil and compared this treatment of these patients to the traditional combined use of cytotoxic medications with high-dose steroids. And what they found is that they were both equally effective in inducing remission of proteinuria. The problem with using MMF combined with prednisone is that once the effect of the high-dose steroid had waned off, then the relapse were significantly higher, with over 80% of the patients having a relapse of nephrotic syndrome. So a case had been made for targeting B cells in patients with membranous nephropathy. Now, the evidence of why we should target such a cells come for a number of experimental studies that show that if we deplete B cells or if you prevent the production of antibodies in animal models, you induce improvement or even prevent the development of membranous nephropathy. But I would argue that the most compelling evidence for the use of a B-cell therapy has been precisely the data by the use of cytotoxic medications in patients with membranous nephropathy, because we should not forget that the effect of cyclophosphamide is mainly because of the direct effects in the function of B cells, and by doing that, it suppresses the secretion of the potential pathogenic immunoglobulin. So it was with this in mind that over 10 years ago, in fact, Dr. Ramuzzi and his group in Bergamo treated 8 patients with membranous nephropathy with rituximab, which is a monoclonal antibody directed to B cells that harbor in their membrane the CD20 molecule. And what this study by Ramuzzi's group showed is that treating those patients with rituximab resulted in induction of complete remission in a couple of patients and partial remission in 3 other patients, suggesting that rituximab could be a potential form of therapy in patients with membranous nephropathy. Subsequent studies again show that the use of rituximab was associated with a significant probability of inducing a partial or complete remission of proteinuria in patients with membranous nephropathy. Another observation for this study was that the response of rituximab, depending on the induction of the disappearance of the antiphospholipase to antibody. And this illustrated here, if the antibody disappeared, then it was associated with a reduction of proteinuria and induction of remission in this patient and also in the second patient. But if the antibody remained in circulation, then these patients did not go into remission. And in an additional observation is that patients who achieve remission of proteinuria, in the reappearance of the antibody was associated with relapse of the disease. Subsequent work from the Bergendorf group in over 100 patients again show that treatment with rituximab, and in this study with only one dose, with only a small group of patients receiving a second dose in case that the first dose had not managed to achieve B-cell depletion, resulted in the induction of complete or partial remission in over 70% of the patients. So based on these observations, there is now a randomized control study being done testing the benefit of rituximab versus cyclosporine in patients with membranous nephropathy. And the idea is that those patients are going to be randomized to either receive rituximab or cyclosporine. The treatment will be done basically for a year. At 1 year, those patients will stop treatment and they will be observed by another 12 months, with the end point being at the end of 24 months from randomization date, and testing really which drug is more effective not only in achieving remission, but also in maintaining long-term remission in patients with membranous nephropathy. More recently, there has been also interest in looking at ACTH. ACTH may have a number of potential benefits in the kidney via reduction of inflammation, direct protection to the podocytes by inhibiting of apoptosis, increased tubular regeneration, all of which potentially could result in reduction of kidney injury, reduction of proteinuria, and therefore remission of nephrotic syndrome. Now, Dr. Ponticelli was the first to test this in a pilot study where he randomized patients to be treated to receive either a synthetic version of ACTH called Synactin that is not available in the United States against patients treated with the traditional prednisone and cyclophosphamide regime. And what he reported is that both treatment, either patients treated with the prednisone cyclophosphamide group or with Synactin for a year, had a similar number of patients achieving remission of proteinuria. And the first data that we have about the use of ACTH in the US came from Dr. Andrew Bambach and his group at Columbia, and found in 11 patients treated with this medicine, there was a significant number of patients achieving complete and partial remission. Subsequent to that, there was another study to determine the efficacy of the porcine version of ACTH. In this study, 20 patients were studied. These are the baseline characteristics of the group. Patients have nephrotic syndrome documented by a proteinuria baseline of 9 grams in a serum albumin of 2.7. And at the end of 12 months, you can see that there was a significant reduction of proteinuria from baseline, as well as improvement of the serum albumin. Another interesting observation of this study was that the response was dependent on basically the cumulative dose. In other words, patients who receive a mean of 880 units didn't really respond to ACTH, while treatment with a cumulative dose greater than 1,700 units was equally associated with response, which equivalent to treating for at least 3 months with 80 units twice a week. Similarly, to the findings of patients treated with rituximab, the response to ACTH also appears to correlate with the response to the antiphospholipid antibody levels. So I would like to conclude by saying that preliminary data suggests that both rituximab and ACTH are potential treatment for patients with idiopathic membranous nephropathy. Both decrease proteinuria and result in improvement of other measures of nephrotic syndrome in these patients. For rituximab, there is at least 3 regimens that appear to be effective in inducing remission of proteinuria. For ACTH, it appears that if we are using the porcine version, at least 80 units twice a week for 3 months is required to produce the effect. I would like to emphasize, however, that all treatments are still very effective. And the hope is that in the future, monitoring of anti-PLA2R antibody levels may help to monitor response to therapy. So I would like to conclude by saying that membranous nephropathy is an immune-mediated disease. Sometime in the past, the immune process starts that with time is reflected by the presence of the overt clinical disease manifested by proteinuria. About 70% of those patients, the disease will be associated with the presence of antiphospholipid 2 receptor antibody. And data so far suggests that disappearance of the antibody equals remission of proteinuria, with patients either going into complete or partial remission. And I would argue that that's an important point to take home, because in a patient who was positive for the antiphospholipid antibody at the beginning of immunosuppressive therapy, in which immunosuppressive therapy resulted in disappearance of the antibody, the residual presence of proteinuria reflects the structural damage of the glomerular disease rather than active immunological disease. And in this situation, the treatment of these patients should be with maximizing conservative therapy and not by escalating further immunosuppression.
Okay, that was a video so long. Application in medicine. Recent data suggests that B cells play a key role in the pathogenesis of a number of autoimmune diseases, including membranous nephropathy, and that selective depletion of B cells in humans may be beneficial in preventing the production of pathogenic immunoglobulins a subsequent renal injury. Another video.
Hi, my name is Fernando Fervenza. I am nephrologist at the Division of Nephrology and Hypertension at the Mayo Clinic in Rochester, Minnesota. My area of interest is to conduct translational studies in patients with glomerular disease. And today I'm here to introduce you to a new study we are conducting in patients with membranous nephropathy, aiming to evaluate the effect of therapy with rituximab versus cyclosporine in patients with membranous nephropathy and nephrotic syndrome. Membranous nephropathy is a common glomerular disease. It's the most common cause of nephrotic syndrome in Caucasian population. And because of the severity of nephrotic syndrome in patients who do not go into remission, there is a tendency to progress to damage and resulting in end-stage renal disease, and 40% of those patients will need either dialysis or transplantation long term. Now, the best prognostic factor for patient with membranous nephropathy is, in fact, a remission of proteinuria. And as illustrated by these slides, patients who go into complete remission, meaning no protein in the urine, they have an excellent long-term outcome. But even patients who have like a partial remission of proteinuria, meaning that the proteinuria goes to levels below 3.5 grams per 24 hours, they still do excellent long-term. But if your proteinuria remain on the nephrotic range, then the outcome is very poor, with 80% of the patients really going to require dialysis transplantation long-term. I think there is no question that the target of therapy for patients with membranous nephropathy is remission of proteinuria, because we know that if we get rid of the proteinuria, those patients will do very well long-term. Now, we do have available therapies for the disease. The best proven therapy for patients with membranous nephropathy is what is called the Ponticelli regimen. It's a combination of prednisone and cyclophosphamide, or a combination of prednisone and chlorambucil. In the studies done by Dr. Ponticelli show that patients treated with this combination have a 92%.
Okay, this video told us about the same information of the last video. Pros. There is no specific treatment for membranous nephropathy. Supportive care with the use of diuretics and angiotensin converting enzyme inhibitor in combination with angiotensin II receptor blocker is recommended, but these agents have only a limited effect. Immunosuppressive treatment options include the use of corticosteroids, alkylating agents, cyclosporin A, tacrolimus, and mycophenolate mofetil, but their use is controversial. Not all have been shown to be effective, and their use can be associated with significant adverse effects. Cons. Signs and symptoms of membranous nephropathy include swelling in the legs and ankles, weight gain, fatigue, poor appetite, frothy urine, elevated fat levels in the blood, hyperlipidemia, increased protein levels in the urine, proteinuria, decreased protein levels in the blood, particularly of the protein albumin. Issue apply in Ecuador. Idiopathic membranous nephropathy is an autoimmune disease. In approximately 70% of patients, it is associated with autoantibodies against the phospholipase A2 receptor 1, PLA2R1, and the gene targets in the remaining patients are unknown. Okay. Thanks.